Hello, welcome back. Today I shall be discussing about parathyroid independent hypercalcemia. So the features are PTH secretion is appropriately suppressed and it is usually lower than or normal or undetectable, the PTH levels, and most affected patients have malignant hypercalcemia. These are the causes of parathyroid independent hypercalcemia. The number one cause are neoplasms, so which they could be PTH-RP dependent, or it could be other humoral syndromes, or they could be a local osteolytic disease including METs. There could be a non-neoplastic PTH-RP excess. The second important cause could be excess vitamin D action. Either it could be due to excess vitamin D itself, or it could be due to granulomatous disease, or like sarcoidosis, or it could be due to Williams syndrome. And other endocrine conditions apart from the hyperparathyroidism could increase the blood calcium levels independent of parathyroid, and these are thyrotoxicosis, adrenal insufficiency. And you could have hypercalcemia in renal failure as well, both in acute and chronic renal failure. Immobilization and Jansen's disease could also cause parathyroid independent hypercalcemia, and the following drugs like vitamin A, Milk-alkali syndrome, thiazide diuretics, and theophylline also could cause that. So in this lecture we shall examine each of these causes. Coming to hypercalcemia of malignancy, it could be of two types, as I've told you before. It could be by the humoral mechanism, or it could be by osteolytic hypercalcemia. So most malignancies produce hypercalcemia only when they are far advanced, and usually the patients present with classical signs and symptoms of hypercalcemia, and they die 1 to 2 months after hypercalcemia is discovered usually. And there are dramatic changes in mental status culminating in common. Because albumin is low, and it could lead to an apparently normal total blood calcium, but the ionized calcium levels will be high, and this could result in the features of hypercalcemia. And the manifestations often overlap those of the underlying malignancy. That is, the features of hypercalcemia and the features of the cancer and the features of cachexia could overlap. And the treatment is, because resorption of the bone plays a pivotal role in pathogenesis, treatment usually consists of volume restoration and followed by inhibiting the calcium formation by inhibiting bone resorption, that's by bisphosphonates or denosumab. And the only effective treatment of underlying neoplasm can only significantly influence the long-term prognosis. So osteolytic hypercalcemia it occurs in two cases. One is in multiple myeloma and the other is in patients with breast cancer, especially with METs. So in myeloma, active osteoclasts are found near the tumor cells, and they are the mediators of bone resorption. And numerous cytokines and chemokines are capable of stimulating bone resorption. They include the MIP1, TNF-beta, and interleukins 1 beta, 3 and 6. What do these factors do? They lead to the increased expression of RANKL, and this in turn leads to stimulation of osteoclast formation and activity. And the bone is further weakened by the suppression of bone formation by the secretion of DCOP1. DCOP1 is an inhibitor of WNT signaling, and this is secreted by the myeloma cells. However, in the osteolytic hypercalcemia in breast cancer is not fully understood. There could be a host of cytokines responsible for this, especially TGF-beta, and they have elevated levels of PTH-RP. This could be the circulating PTHRP, or it could be that produced in the bone by the metastatic tumor cells, and this can produce the hypercalcemia. And primary breast tumors that stain PTHRP are more likely to result in bone mets. Humoral hypercalcemia of malignancy. It's characterized by high blood calcium, low blood phosphate, and high urinary cyclic AMP, like those found in primary hyperparathyroidism, but there is no elevation in the intact PTH levels. Here the PTHRP binds to the PTH/PTHRP receptor, and it mimics all the actions of aminoterminal fragments of PTH. And antibodies against PTHRP can reverse this hypercalcemia. It's characterized by low levels of 125 vitamin D3 hydroxyl D3, because there is weak activation of the renal 1-alpha hydroxylase in humans by PTHRP, and there is an inhibition of 1-alpha hydroxylase by hypercalcemia or tumor products. Since the 1-alpha is weakly activated by PTHRP, the inhibitory effect of the hypercalcemia dominates, so the levels of calcitriol are low. And the sources are, it's caused by squamous cell cancers of the lung, head and neck, esophagus, cervix, vulva, skin, breast cancer, renal cell cancer, and bladder cancer. So it's caused by a lot of cancers, and they secrete numerous cytokines, which could be also resulting in human hypercalcemia. And also immobilization and fragments of PTHRP with novel properties could also result in hypercalcemia. An HTLV-1 infection is the only hematological malignancy commonly associated with PTHRP overproduction and hypercalcemia. There is a relation between cachexia and PTHRP, so it often accompanies the hypercalcemia malignancy. And administration of monoclonal antibody to PTHRP ameliorates this cachexia, not simply by lowering the blood calcium, but it also blocks the ability of PTHRP to convert white adipose tissue to brown adipose tissue. That is, it inhibits the browning of adipose tissue, and the browning of adipose tissue causes cachexia. Now coming to the excess vitamin D action, it could be due to excess vitamin D, or it could be due to sarcoidosis and other granulomatous conditions, or it could be due to the Williams syndrome. Vitamin D intoxication. The synthesis of calcitriol is so tightly regulated that extremely large doses of vitamin D, like 1 lakh unit or 100,000 units per day, are required to cause this. And most cases are iatrogenic. Occasionally inadvertent ingestion occurs, especially in kids, and it presents with nausea, vomiting, weakness, and altered level of consciousness. It can be severe and prolong the hypercalcemia because of the storage of vitamin D in the fat. When we look at the blood picture, PTH levels are suppressed, and the levels of 25-hydroxy D are dramatically increased, while that of the levels of calcitriol are only modestly elevated, or even can be normal. This is due to the down-regulation of renal 1-alpha hydroxylase because the PTH is low, and the high levels of phosphate, calcium, FGF23, and 125 hydroxyvitamin D itself. These can all down-regulate the renal 1-alpha hydroxylase, and it will result in a low level of 125 hydroxyvitamin D3, whereas the 25 hydroxyvitamin D will be drastically elevated. The reason for hypercalcemia results from increased intestinal absorption of calcium, and also from the direct effect of calcitriol to increase resorption of bone. So in severe cases, bisphosphonate therapy can be usefully added to therapeutic regimen of hydration and omission of the dietary calcium. Coming to sarcoidosis and other granulomatous disease. Sarcoidosis is usually associated with hypercalcemia and even more commonly hypercalciuria. They got high levels of 125 hydroxy vitamin D3. So it causes the hypercalcemia by increasing the intestinal absorption of calcium, and the PTH levels are suppressed in this condition. And there is unregulated synthesis of calcitriol. It occurs not in the kidney but in the sarcoid granulomas. And hypercalcemia and high levels of calcitriol fall upon treatment with glucocorticoids, because this increased calcitriol is produced by the macrophages, in fact, and the glucocorticoids suppress their activity. The mechanism is through macrophages. They express the gene encoding a gene which is very similar to the 25-hydroxylase, very similar to the 1-alpha-hydroxylase found in the kidney. So it is stimulated by the interferon gamma. These macrophages are stimulated by the interferon gamma, and hence lots of vitamin D is produced. And there is an unusual increase in the number of activated macrophages in sarcoidosis, and this leads to elevation of blood calcium. And they also have unusual sensitivity to vitamin D and become hypercalcemic in response to even normal ultraviolet radiation or normal vitamin D intake. And removal of a large amount of granulomatous tissue has been found to reverse this hypercalcemia. Other granulomatous diseases associated with hypercalcemia include tuberculosis, fungal infections, berylliosis, Wegener's, AIDS-related pneumocystis jirovecii infection, fat necrosis of the newborn, and Crohn's. Coming to Williams syndrome, it's a developmental disorder characterized by supravalvular aortic stenosis, Alpin facies, and mental retardation. And hypercalcemia transiently occurs in the first 4 years of life. And patients have higher than normal calcium levels usually, and they are at the top of the normal range. And it is due to increased intestinal absorption of calcium and increased calcitriol that falls to normal as the blood calcium normalizes. The hypercalcemia can be manipulated by diet and, if needed, by bisphosphonates. Williams is a contiguous gene syndrome with deletions of one or several genes, and mostly genes for elastin have been implicated. So Williams syndrome transcription factor, it can bind with the vitamin D receptor and influence the transcription of VDR responsive genes. For this reason, this gene is a strong candidate for the gene associated with transient hypercalcemia in Williams, even though there has been no evidence for this. And the two important endocrine conditions other than the hyperparathyroidism that are associated with hypercalcemia is hyperthyroidism and adrenal failure. So hyperthyroidism is characterized by mild hypercalcemia. It seldom exceeds 11 mg per deciliter. It's due to direct action of the thyroid hormone to stimulate bone resorption, characterized by low PTH levels, low calcitriol levels, and hypercalciuria. And beta blockers can reverse this hypercalcemia. In adrenal insufficiency, there's a combination of influx of calcium into the vascular space. It could be coming probably from the bone, and also there is a low renal clearance. And hence blood calcium is elevated partly as a result of the hemo concentration and increased albumin levels as well, but the level of ionized calcium can also be increased. Jansen metaphyseal chondrodysplasia is a condition where there is abnormally organized chondrocytes in growth plates, and this leads to generalized defect in endochondral bone formation. It is due to a constitutive action of the PTH-RP receptor, and it is caused by 5 different point mutations. And PTH-like actions of the receptor in bone and kidney, and PTH-RP-like actions of the receptor on the growth plate results in this condition. So there is a constitutive action of the PTH or PTH-RP receptor, and the receptor in the bone and the kidney will respond as if it is bound to the PTH, and on the growth plate it will have the PTH-RP actions signaled. The features are, it's a very rare disease, and the affected persons are present in childhood with short stature and hypercalcemia, and there is high calcium, low to normal phosphate, and high vitamin D levels. Also, there's a high alkaline phosphatase and high urinary hydroxyproline levels, but the PTH levels are suppressed. So this is the typical photo of a patient with Jansen's. You can see when she is almost 3 years old and when she is 22 years old. You can see that this is characterized by dwarfism. Coming to vitamin A toxicity, so it occurs when the hypercalcemia occurs when the vitamin A is ingested 10 times the recommended dietary allowance, and it is thought due to the action of retinoids to stimulate bone resorption. And the diagnosis is through association of a history of excess ingestion of retinoids with the characteristic syndrome and abnormal results of LFTs. There will be also elevated vitamin A levels, and this confirms the diagnosis. So treatment involves hydration and, if necessary, glucocorticoids or bisphosphonates. Coming to thiazides, they don't usually cause much of hypercalcemia in normal state, but they can exacerbate the hypercalcemia of primary hyperparathyroidism or any other cause. So usually these thiazides increase proximal tubular calcium reabsorption, and it is due to an action on the distal tubule, and this transient hypercalcemia suppresses the PTH, and hence the calcium homeostasis will be balanced, and therefore they do not cause hypercalcemia by themselves. But if the PTH cannot be suppressed, as in conditions like primary hyperparathyroidism, they can exacerbate the hypercalcemia. And when you administer the thiazides for a long time, it results in chronic hypercalcemia in patients having abnormal parathyroid physiology, but not in normal subjects because of the negative feedback on PTH. Milk-alkali syndrome, it's characterized by a triad of hypercalcemia, metabolic alkalosis, and renal failure. So this was much common in the past due to the because lots of sodium bicarbonate was used in the treatment of peptic ulcer disease, but interestingly it is now reappearing due to the increased use of calcium carbonate to treat dyspepsia and osteoporosis. So a vicious cycle occurs where alkalosis decreases the renal calcium clearance, and the hypercalcemia ensuing will maintain the alkalosis, so the alkalosis again decreases the calcium clearance. So a vicious cycle happens there. It's characterized by nephrocalcinosis, nephrogenic diabetes insipidus, and a decreased GFR when it is quite severe, and it could result in renal failure. And PTH levels are low. And coming to the renal failure, hypercalcemia can occur in acute renal failure as well as in chronic renal failure. So during the oliguric phase, there is a severe hypocalcemia. This is because of the acute hyperphosphatemia and calcium deposition in muscle. But when there is when the diuretic phase happens, there is hypercalcemia because there is mobilization of calcium depots, and also in a fraction of the patients there is increased calcitriol. And in chronic renal failure, hypercalcemia usually results from tertiary hyperparathyroidism, or when you give therapy for aplastic bone disease, or when there is aluminum toxicity. Immobilization, hypercalcemia has been found in this condition quite commonly, and it usually happens after trauma or after spinal cord injury. So after trauma it's quite common. This is because of the high rate of bone turnover, and there is increased resorption and decreased bone formation. After spinal cord injury, hypercalciuria is maximal at 4 months. Bisphosphonates and denosumab have been used in this. Thank you.